So again, there's my contact information. Anything that I go over today, or anything else you want me to talk about, cancer statistics, causes, whatever, please give me a call or an email. So you should all know this by now, I think. I don't know if in medical school you get much epi. Epidemiology, as in the word epidemic, is the study of the distribution and determinants of diseases. Epidemiologists sometimes called disease detectives. So what we want to do is look at the statistics that we just looked at, figure out what do we know, what don't we know in terms of causes, and do research so that we can understand better why these rates of cancer are going up, down, or sideways. We need to identify risk factors or exposures, and this could be environmental exposures, it could be something genetic, that together are causing cases of cancer. Fundamental science of public health. So we use epidemiologic data. Epidemiology is said to be a population science. So we study groups, and we study smokers versus non-smokers. We study people of different races. We compare their rates, their risks, and try to figure out exactly what is the mechanism, what is the cause of cancer. Okay? Beyond cancer epidemiology is a topic or kind of a field of something called cancer control. Cancer control means this. It basically puts you in public health, which some of you are and others maybe will partly be in there one day, whether you're physicians or not. Cancer control means, okay, now that we know what we don't know everything about cancer. We know smoking causes lung cancer. We know some risk factors for breast cancer. We know this, we know that. Epidemiology and public health are, you might say, applied sciences. There's that line, inquiring minds want to know. But we don't do epidemiologic research just to publish a paper and say, isn't that interesting? It's supposed to go toward lifting the cancer burden, is the case, or is the phrase used, from the population. So we want to make things better. We usually need to measure something to show that we've made progress. So in cancer control, you're intervening. You're saying, okay, the lung cancer rate in this community is really high. Let's start a smoking cessation program. Obesity is a risk factor for different cancers. In this area of the state, we need to have a program in physical activity, weight reduction, so on and so forth. In some other area of the state, maybe there's no colorectal cancer screening. We need some funding to pay for screening tests, because if we can detect the disease early, chances of cure are very high. Okay? So that's what cancer control is all about. So as opposed to epidemiology, cancer control is kind of interventional. It's doing something with the knowledge we have. How do you prove or demonstrate that you've done some good? Hopefully you have. Well, things that we measure, again, epi terms, incidence, occurrence of new cases, mortality as deaths, survival, and another arm of that is quality of life. So we used to be, I guess we still are, kind of focused on numbers like this patient survived cancer for 25 years. Isn't that great? Probably it is. But the other element is what was the quality of life before and after the cancer diagnosis. So cancer control says, okay, how can we make things better or help the cancer survivor get back to the life that he or she had before the cancer diagnosis? Okay, approaches to cancer control. The main thing we like to do in public health is actually, if you're a public health person, you are working more with well people than with sick people. So the ideal in public health is, as opposed to maybe clinical medicine, where you have a sick person, you have to diagnose and treat them, and that's great, that's what I would like when I'm sick. In public health, we say, okay, let's find people that don't have cancer and help them never get cancer. Help them stop smoking if they're smokers. Help them change occupations if they're in something hazardous. Do whatever needs to be done to keep a healthy person healthy, that is cancer-free. Okay? So that's the ideal, is prevention. Now for prevention, you have to know what the causes are. So for many cancers, we need to do more epidemiologic research. Like, what causes breast cancer? I don't really know. I know how to screen for it and detect it early, but how to prevent it, I know bits and pieces, but nothing that really answers the question, how do you prevent breast cancer? Okay. Primary prevention, again, if you're on the elevator in the professional meeting with President Obama and Vice President Biden. And Vice President Biden, is into the cancer moonshot, and he wants to make a statement, do something big for cancer. You're on the elevator going to the 9th floor to the next set of meetings, and they say, well, we didn't have time to listen to that last lecture. We were on the phone with the CIA. Can you tell me in the next 30 seconds, because the elevator's moving, what causes cancer? How do I prevent cancer? So you would quickly say, as quickly as you can talk. Now, not all of these bullets apply to each and every type of cancer, but altogether, this is what we know. You want to reduce tobacco use, decrease that, increase physical activity, decrease your weight, control your BMI, decrease ultraviolet light, radon. That's what to do. And the elevator's doors open, and then you go your separate ways. Now again, tobacco use, for instance, has nothing to do with breast cancer. So smoking or not, as far as research has shown, doesn't cause breast cancer, doesn't prevent breast cancer, not relevant. It's not in the mechanism of getting that. But it does, of course, cause lung cancer, pancreatic cancer, and several others. Okay. In EPI, we talk about multifactorial etiology. That is, there are usually many ways to get a certain cancer. So we'll go back to lung cancer. The main way, statistically, numerically speaking, is using tobacco. But you can find people that never used tobacco, but they got lung cancer. How did they get it? Well, there's so-called passive smoking, which you may or may not put in the same category. You live with a smoker and you breathe in their smoke. Aside of that, we have radon, a radioactive gas that's in the earth. Certain counties in Alabama, especially around Huntsville, have high radon levels. And if you live in a house where the radon's coming up, you can get exposure enough to cause lung cancer. Another is certain types of asbestos can cause lung cancer. So there's an occupational way. So the idea of multifactorial means be open to the idea that we're not going to find one and only one cause of breast cancer. There's going to be different ways that you can get breast cancer, and we need to find out about all of them. Okay? That being said, for the cancers in this country, there's usually kind of a more common way than other ways, like tobacco more common than radon as a cause. Okay? So there are tobacco-related cancers. These are the ones that I think of. I won't read them to you. You got the slides. Obesity and diet. They're the sites I think of first. Chemical exposures, urinary bladder, to some extent breast, prostate. Now there's something called the International Agency for Research on Cancer, the IARC, that's in Lyon, France. And they do monographs on environmental exposures, chemicals. A lot of them are occupational chemicals that cause cancer. That's the bad news. I mean, I could tell you, I can't tell you now because I don't remember. I could give you the chemical formula for a lot of chemicals that they're going to give you cancer if you inhale them or get them on your skin. That's the bad news. The good news is almost none of us in this room are exposed to these chemicals. You have to be in an occupation where you're not protected from some particular exposure. Okay? So usually on occupation, some people think cancer is caused by occupation. The current thought is only about 5% of cases. So if you happen to work in a certain occupation with certain chemicals or certain gases where you're not protected from volumes of exposure, yes, that could give you certain cancers. But across the population, very few people, very low percentage are exposed that way. Okay? There's also infections. So the idea in cancer, of course, is there are genetic changes because cells are multiplying out of control. Often, though, there's an environmental insult. So there's a virus, there's some radiation, there's a chemical that's, again, stopping the mechanisms to control cell division. Okay? Okay, we can't prevent all cases of cancer in all people. It would be foolish to think we had that power. In addition to, sometimes instead of, but at least in addition to or instead of, secondary prevention. Now here you're not preventing a new case, which is the ideal. You're preventing an extreme case or death, or that's your goal. Okay? How do you accomplish secondary prevention? I think of it in 3 categories. One is simply health education. To inform people, here we're in the ivory tower, we're all medically related, trained in one way or another. We know bleeding from certain places or lumps in certain places, there's something wrong. But not everyone would react to that. change in their body. So there's some education about here's what's normal, here's what's not, here's what you need to do if you have this or that change in your body. Go to a physician, go to a clinic. Okay, that's very simple, straightforward, and that I think should be done. The second arm for secondary prevention, this is a little more controversial, self-examination. And we say breast or testicles is not really done. Testicular cancer is not a very common cancer. It's among younger men, like late teens and 20s. And in retrospect, if a young man gets diagnosed with testicular cancer, he or the doctor could probably feel it right there because the anatomy is there, but it's usually not taught. So let's talk about breast self-examination. The data are not so good. That is, the breast self-examination is an art and a science taught by physicians, nurse practitioners, others. For a woman to examine her breasts once a month or maybe more often, looking for an odd lump or bump that's different than the bumps that maybe occur in the menstrual cycle. So a lump that's especially hard or seems fixed or something, that's an art to learning like what's within normal range and what's a lump or bump that we're concerned about. The problem is testing women and then saying goodbye, and then like anything you teach somebody new, there should be like refresher courses, like come back every 6 months, we're going to test you, are you doing it right? So enough of that. Controversial. The guidelines are from the ACS and other organizations are kind of like, if someone wants to learn breast self-examination, go ahead and teach it to them, but don't rely on that. And one reason, speaking against BSE, is that some studies have shown that some women who do breast self-examination and think they're on guard, they're on duty, they're going to find an early breast cancer if they have it, they don't do a good job. The other problem is they might say, well, I'm not going to spend my time and money going for a mammogram, breast x-ray, but that's actually the best method. So mammography or breast x-ray, the dose is very well controlled. These days it's not the same machine that they use and dial it down or up when they x-ray somebody's broken foot. There's usually dedicated machines that are only for mammography. So the idea there is that for screening, by which we mean asymptomatic women, in this case, asymptomatic people. So screening in public health means this: if you come with a sign or symptom, I have this lump, I have this discharge, I have this bleeding, could you please screen me for this disease? The answer is no. You wouldn't say that to a patient, but that violates the definition of screening. Screening means by basically your demographic description, your age, your race, your sex, maybe your occupation, maybe some other things about you. Are you at high risk for a certain disease? Now, if you have a lump, a discharge, pain, that's a symptom, you would need diagnosis, and you might get an x-ray. But you would not be the data set for screening, because screening means you don't have symptoms. For example, in breast cancer, the leading, again it gets into the hormonal milieu, the leading risk factor is simply being female. So even though we know a lot of risk factors for breast cancer among women, the American Cancer Society says, well, it's interesting and we understand these risk factors. All we want to know is, are you female and are you 50 years old or over? If the answer is yes and yes, that's all we need to know. You're at high risk for breast cancer, and we recommend you get a mammogram every year, or some organizations say every other year. There's the CDC's U.S. Preventive Services Task Force, USPSTF, that's a mouthful. It comes out with cancer screening recommendations, and so does the ACS. And these are just recommendations. They say, again, for asymptomatic people, we have no specific reason to believe you have breast cancer, you have prostate cancer, but you're of the demographic and maybe occupational profile where we think it's worthwhile for you to get a screening test. Okay? So that's secondary prevention. So for breast cancer, you could do all three. And again, the only controversial one is number 2. Certainly health education for women as they're growing up. What's normal? Be in touch with your body, so to speak. Okay? And mammography. Screen detectable cancers. again, in cancer control, we want to eliminate or diminish the number of new cases. The second goal is, okay, some people are going to get this cancer. We know that because it's impossible to prevent 100%. How do we find it early? Well, you have to have some technology. You can't just do this for every kind of cancer. The cancers that are said to be screen detectable today, where it works, early detection saves lives, are breast cancer, cervical cancer, colorectal cancer, and prostate cancer. Again, I put that as an iffy on the list because of, again, the PSA controversy. But certainly breast, cervix, colorectal. Okay, the third approach to cancer control is called tertiary prevention. So this says, okay, they're going to be cancer survivors. We couldn't prevent their cancer. They got cancer. Maybe they were detected early, maybe detected late, whatever. They had their initial treatment. Now what happens? The ideal is to help that person, that patient, get back to the life that he or she had before. So if a woman used to be the vice president at IBM, stressful job, lots of work, can she return to that job if that's what she wants to do? Okay. If there's a little old man who watched TV most of the day, could walk 2 blocks to get the newspaper at the corner supermarket and walk back home, and he was happy with that, can he at least do that, what he did before? So that's so-called tertiary prevention, doing the best we can post-cancer to get you back to the life you had or better before, okay? So again, for breast cancer example, if there was surgery, mastectomy, or some other related surgery, that there could be some muscle wasting, some mobility problems, also some psychological problems in terms of dealing with differences in the body. So that would be an example of tertiary prevention, a program to get people, again, feeling better about themselves and more confident, okay? We mentioned this already. So cancer control, primary, secondary, and tertiary. Again, primary prevention, epidemiologic research, we need to know what the causes are. If we know what the causes are, we can start to make progress in reducing incidence rates. The slides from the first slideshow are again at cancer.org. This is the course I'm teaching this summer. Too late for you to add it and you don't have time. But if you want the syllabus, email me and I can email you the syllabus, and it has some references, things to read. And again, there are the booklets over there. And I think, I'm 201, 202, but I'm doing pretty well. Thank you for your attention. Again, the slides will be up on the website if not already.